अच्छा वो नहीं रहेगी फिर रहेगी क्या वो तो ये ग्रुप पे डाल देना
ग्रुप पे डाल देंगे अनाउंस कर देंगे
नहीं अनाउंस करके अभी फ्री टाइम है इसलिए बोल रही हूँ मैं तो
हाँ बराबर वही
फ्री
तो
टाइम को किल करने के लिए ग्रुप पे डाल दो ना वो ऑल दीज आर द ये
topics from the online quiz
हाँ
they are
सो
selected for the
सो
hello. We had taken online quiz, so toppers of those will be participating in the quiz, which will be held in afternoon session. So I will take the name. Those who are present here, please they can stand up. Dr. Vaishali Ahire, Dr. Pratik Dange, Dr. Rohini Chandankar, Ekta Jain, Narayan Sanap, Parag Godke, श्रुतिका कदम, तुषार खामकर, स्नेहल बच्चाव, अनासो नरुटे, योर नेम इज हाँ हाँ तो आज बाकी कोई ठीक है नेक्स्ट 10 में से सेलेक्ट करेंगे ना ध्रुवी शाह
And check, check. 1, 2, 1, 2, 3, check.
ओके यस सर वी कैन हियर यू
Okay, am I clear, audible?
यस सर
Okay. That is fine. Okay. चालेल कुठे बसू इथे
फोटो से
या उभं राहायचं ओके ओके Yeah, yeah. Thank you. Hmm. I आता थोड्या वेळ चालू ठेवा असं जे काय झालं, कारण की आता प्रिपरेशनच चालू आहे. एकदा झालं की मी सांगतो इन्स्ट्रुमेंट ट्रॉली दाखवायची आहे. सो आय विल बी इन टच विथ यू. ओके, या या. दत्ता कॉटरी लावून घ्यावी लागेल.
नीचे 6-7 पेशेंट्स है तो साला देख के आओ ना.
My wife is a pedodontist, so I've stolen a lot of material from her. Hmm. Dentist. This is dentist material. Just one number. Uh, can I have this tube a little bit out on this side, like this? Yeah, more on this side, yes. Yeah, better, much better. ठीक है, okay. So, are we all set? Is the audio-visual team set?
Yes, sir, we can hear you and
Okay.
see you also clearly.
Yeah. So, do you have the microscope picture on your screen?
Yes, sir.
Okay.
Yeah.
So, what you can see right now is the tongue with its frenulum.
Yeah.
Okay. And
Yes.
then I am going to cannulate the papilla on the right side.
A
Okay.
small request to the audiovisual people if they can make the colors better.
I think we have a good picture here.
No, you must be, of
Yeah,
course.
yeah.
Yeah. Over here, the colors are very poor, and of course, we can't see papillae also.
Yeah, let me see. When I use the dilator, it will go in, you will realize that it's there.
All right. Yeah.
Okay, yeah.
Yeah.
Uh, yeah, yeah. Also, just give me another minute. I'll just put the endoscope in place. Give me the endoscope, please. Give me the basket. Where's the stores guy? Give me that 11573M basket. Light source on. On करावं लागेल. Intensity on 40. Reduce. Okay. Give me something to focus this on.
What scope is this?
Just a moment, I'll focus it and then I will go through the details. We also have an external camera which will show you. थोडा रोटेट कर. निघतंय त्याला नको धरू. याला धरूच नको. हे धर आणि हा तू धरून ठेव. Okay, give me a gauze piece. Dry one. Yes. I want you to do the white balance from there. White balance करायचं तिकडनं. Okay, fine. Can I have this external camera close? The important thing is because we don't have any landmarks, bony landmarks during the surgery, we need to have our orientation very right even at the beginning of the surgery. So as you can see, I am holding एवढं पूर्ण दिसलं पाहिजे. You can see this scope. This is an all-in-one scope. You can see the tip, the optic tip, but it also has an instrument channel and an irrigation channel all combined into one. So this is an all-in-one scope. The disadvantage is if I have to use a larger instrument channel, I have to change the entire scope. And the scope costs something around 5.5 lakh rupees, or maybe must have increased to 6.5. So this is what I have done is I have oriented the scope in such a way that whatever object I am seeing at 12 o'clock in actual should also be at 12 o'clock on the screen. Okay, so that is one of the most important things to do so that you don't get lost. The other thing is now you can focus here. You can see a bite block in place.
What is that in place?
That's a bite block in place.
All right, yeah.
Purple color.
Yeah.
There's a cheek retractor in place. Okay,
Yeah.
and there's a bolster here in the lower vestibule, so it keeps the lip away from my line of sight.
Yeah.
So all of these have been stolen from the dental department. My wife is a periodontist, so I have stolen all of this material from her. Don't tell her, she doesn't know.
Can't hear you well now.
Okay, can you hear me now or no?
Yeah, muffled. It was good, but suddenly it has become muffled.
Okay, somebody from the audio team, can you just correct this? Basket.
Yeah, voice is better now.
Better? Okay.
Yep. Thank you, audiovisual.
Yeah. Sir, good to hear your voice too.
Sir, my pleasure.
So I said, don't tell my wife I have stolen these things from her.
What is it? No, I didn't get you.
Hello?
Yeah, yeah, yeah.
So, am I audible or am I not?
You are very well audible.
Okay.
Only one request to the audiovisual, if they can adjust the color over here,
Right.
it would be great.
Yeah, okay. I
That-
want that newer basket. That one, yes. So we have everything in set. We just are getting the basket onto the trolley. In the meantime, I will show you the trolley. These are the dilators, as you can see. Am I audible quite well? Or
Yeah,
no?
very, very clear, very
Okay.
clear. Absolutely
So-
nothing to,
Right. So this is a set of 5 dilators.
yeah,
These are in that sense blunt.
yeah.
Then we have 2 conical dilators.
Mm-hmm.
One is sharp, one is a little blunt
Uh-huh.
for the modular scope.
Yeah.
But I am using an all-in-one.
Mm-hmm.
Just about that, that's the instrumentation that's required. This is a guide wire.
Yeah. Correct. Yeah.
And this is a Dormia basket. You can see it opening.
Yeah. Very clearly seen. Yeah.
And
Now,
also-
what is 1173 in that?
That's the number of the basket that the source people identify it with.
All right. Yeah.
Yeah.
Yeah. Very clearly seen. Yeah.
Okay.
Yeah.
So I think we are set. Are we set? Or is your color problem resolved?
Yeah.
Okay.
No, I mean, I don't know. Once we get on the scope, then we will know
Okay. Now, back to the microscope camera. Let me know when you are on screen.
it. We are.
Okay. For the audience, Dr. Indarwala has been instrumental in my growth as an ENT surgeon and also as a SIALENDOSCOPist, because he was the first one to encourage me to get into this field. And I'm really thankful that he has been here standing behind me all these years. Thank you, sir.
Sir, you make me humbled. That's all.
Are you in focus? Is the camera in focus for you?
All right. Sort of. Yeah.
Yeah.
Not the best, but I
Okay.
think we can go around.
Yeah.
Yeah.
Give me the number
The,
one
the, the,
dilator.
the real thing is once you get on the scope.
Right.
Yeah.
So
Yeah.
this is the frenulum of the tongue.
Yeah.
This is the mound of the submandibular papilla.
Yeah.
Can you see this papilla here?
Yes.
Okay. Let's see if we can see the papilla on the other side. Should be here. I'm not going to probe in too much on that side. Can you see this dilator going in?
Yes.
Okay. Sometimes, as I said, it's a bit tricky. You have to be very careful about handling the papilla.
Yes.
Can you now see
Yes.
how delicately I have gone in?
Yes.
And if you look closely at the dilator, you will see a black line just above the papilla.
Yes, we can.
So I generally put in my dilator only up to that depth.
Uh-huh. Can you centralize the microscope?
Okay, let's see.
Yeah, much better. Yeah.
Okay. And what my assistant does is, he dips the dilator in saline. You can see a little bit of saline on the dilator, because you don't want to put in a dry dilator into the papilla.
Uh-huh.
So even if it takes time, it's fine, because we are going to conserve an organ. So time should not be of prime importance. The dilatation has to be delicate, as far as possible non-traumatic, because bleeding will hamper our vision. Can you now see the papilla much better than before?
Yeah, we can, yes. Shirish, sometimes you just can't get this step
Right.
right. I mean, you know, you get defeated right at the beginning. Have you experienced, and what do you do?
Yeah. So the thing is, when I do not find the papilla, there are a few tricks. One is, it begins even before you are in the OR. For every patient that complains of a mouth symptom, you can put him under the microscope. As ENT surgeons, we always have a microscope handy, and get used to the variation in anatomy that is there.
Right.
The second thing is, once you are in the OR, what you can do is identify the opposite side. Generally, they are
Similar. Yeah.
The third thing is, if you cannot do that, sometimes pre-op, before the patient is induced, I give half an hour ago, before induction, a tablet of vitamin C, chewable vitamin C.
Orally.
Yeah, orally.
Yeah.
So that I can massage the gland and see where the saliva is coming from.
All right.
And the fourth way is,
even after induction, does this?
Even after induction it works, because we have not paralyzed those reflexes.
All right. Yeah.
But it is always better, because it becomes a bit clumsy. That paste of the tablet keeps on coming in between. Right. So the fourth thing that you can do is infiltrate saline just submucosally.
All right.
So the entire surface of the mucosa stands up like a dome, and the papilla is a saucer, a depression on it.
Right.
And even if this is not possible, then you can do a cut down, find the duct, and retrograde come to the papilla.
Then you can do what?
Cut down on the floor of mouth.
All right.
Identify the duct. And when you are dissecting, the duct is the only structure linear some time to dilate. And because the picture has been lost, probably the audiovisual guys also want me to keep the dilator in place for some more time.
Yes.
Can I have this picture here, please? Okay. Okay. Are you on screen?
Yes.
Okay. So if you notice, if you look at the dilator, let me see, can you see there are 3 rings to the dilator?
No, we are not in the center. Just
I mean, it will be difficult. I'll probably. Can you now see?
all right.
It will be out of focus, but there are 3 rings.
Yes.
Yeah, that's how you identify the dilator.
Yeah.
So now I will use a number 4. You could see saliva coming out.
Yeah, we did.
Yeah. So this is number 4.
That is a black ring. Yeah.
Yeah, black end. But with experience, you can go in deeper also.
Yeah.
Now you can see 4 rings on this one.
Perfect. Yeah.
Right. Can you see the papilla gripping the dilator?
Yes.
Yeah. So that for me means we have to wait a little while so that it dilates.
Yeah. Anatomically, do you have muscular ring around this, or
Yes.
Yeah.
There is. histopathologically it is proven that there is a muscular ring around it.
Yeah.
And there are, I mean, again, as in most of the subjects, two schools of thought. One thing that it is a rudimentary muscle, the other thing that it is an active muscle. But believe me, you have done silendoscopy, sir. Believe me, sometimes you dilate by number one, but by the time you get in with the number two dilator, it has shrunken to its original size.
Yes.
So it certainly is active. In my mind, there is no doubt that there is an active sphincter
It's
at
an
the
active
papilla.
muscle, yeah. Yeah, yeah. I mean, the inactive muscles would disappear, I believe so, you
Yeah.
know.
Now you see it is gripping the dilator less as compared to before.
Ah,
The rotational movement is
it's
less.
easy, yeah. Yeah.
Can you now see the size of the papilla?
Yes, very clearly also. Is it number 5 now
Yes,
or the
it is
same
number
one?
5.
Yeah.
Sir, I am using a different set of dilators than what Professor Francis Marshall uses,
Mm-hmm.
because he has 12 dilators from 0000 to 0 to 1 to 3 to 8.
All right.
Yeah, but I use a set of 5 dilators,
Mm-hmm.
and I've always believed it's all in the mind. If I were given 75 dilators, each increasing by 0.01 millimeter, I would have used that. If I had only 3 dilators, I would have used 3.
Mm-hmm.
Now my assistant is going to hold on to the dilator. I am going to check with my scope once again. Wait. I'll tell you when to shift. Okay, I have the orientation in place, right? By orientation, I mean 12 o'clock should be 12 o'clock.
Yes.
Yeah. Okay. So, wait, I'll tell you when to switch.
To the audience, I would be happy if you have any questions passed over to me so that I can ask him, or you can take the mic and talk directly. There is absolutely no problem. It's a very small gathering and we can take full advantage of an excellent international surgeon.
If you can see, now the diameter of the scope is much lesser than the diameter of the dilator. Can you appreciate that?
Repeat, I'm sorry, I didn't get you. Diameter of?
The scope
Is
lesser
less,
than
yes.
the diameter of the
Yeah.
dilator, so
Yes.
that it will go in.
Right.
So
Yeah.
I'm sure that it will go in.
Yeah.
Now slowly my assistant will rotate and remove this. Mr. Datta Zopre is my assistant. He has been with me for all the nearly 500 cases that I have done. So you'll find very good assistance from his side. Can you see the scope going in?
Yes.
Okay. Fine. Now we'll shift to this screen. Guide wire, please. Now you can have the external camera as picture in picture.
Yeah, we have it.
Right. So you can see I have right. Can you see now how am I holding the scope?
Yes. All right. Now we can see.
And you can see the 3 channels, the optic element, the guide wire through the instrument channel and the irrigation port.
Yes.
Okay. Now, because my lens of the scope is touching the guide wall, the duct walls, you have a whiteout on the screen. Okay?
We can't see that, but anyway.
Okay. I mean, tell me when you have the endoscopic picture in place.
Yeah, we should have picture in picture and yeah.
Right.
All right.
Okay.
Perfect.
So
Yeah.
now what I'm going to do is I'm going to ask my assistant to irrigate.
Yeah.
At the same time manipulate the scope forward and backwards in order to get a lumen.
Correct.
And as in all scopies, it is you keep the lumen in center and progress further. You keep the lumen in center and progress further.
Right. For almost any scopy that we do.
Yeah,
Yeah. No, let us have endoscopic picture also, please.
You have the
Right, that's it. Perfect. Now don't keep it like that. Audio visual, keep this is perfect. Keep it like that.
Can you see the green thing is the guide wire?
Yes.
It is just coming into view. I am going to manipulate it. Manipulate my scope.
Yes, we can see it now.
Right. Irrigate, please. Irrigate. I think I can see a small tributary there.
Yes, we can see that. Yes.
So it could be possible that I have bypassed the stone and gone beyond. Depending upon the sonography and the palpation, the stone should have been distal to where I am right now.
Correct. Yeah.
So I am going to withdraw my scope with the guide wire in place. Can you see the beautiful vascularity there?
Vascularity, no.
Okay. Probably on my screen it is much better.
Yeah. I can see some vessels, yes.
Yeah. Now you will get a glimpse of those
Vessels, yeah.
Yeah, at 12 o'clock you will see now
Correct.
the vessel.
Yes.
Yeah. So this puff of cloud tells me that generally there should be a stone around, because the stone isn't a kind of a dry structure, it's a wet structure. It has biofilms over it. It has some protein membranes. It has mucus which is sticking to it.
Mm-hmm. Yep.
Can you now see this?
Yes.
Okay, so what I'm going to do is, like this, the basket will go in. This is the guide wire.
Yeah.
Fortunately, the stone appears to be floating.
Yeah.
There doesn't appear to be too much of a stricture.
Yeah.
And we are ready for a combined approach if the stone gets struck.
Right. All right.
So
yeah.
now I am going to withdraw the guide wire. Irrigate. And this is withdrawn and kept my scope there. My assistant is going to feed the basket through the instrument channel now.
Yes.
हे याच्यात पुश कर, इन्स्ट्रुमेंट चॅनल मध्ये पुश कर खालचं. राईट.
Ghan sir, it is so beautifully seen कि if we do with the normal approach, we can never appreciate this floating stone. So beautiful it is looking.
And the most dangerous, I have had cases where somebody has tried to open the floor of mouth, and this is a floating stone, it moves more proximally and then you are lost.
Yeah, that is the thing.
Irrigate. That's the basket being deployed. But it is still not reaching because the basket length appears to be smaller than what. So I'm using opening, closing the basket to try and move the stone more distally. Irrigate.
You have fully inserted the
Yeah, I have fully
basket.
inserted the basket, but it's still not reaching. Somehow,
Yes.
I may have to. Okay, irrigate. I may have to pass the scope more inside.
That basket, total
The
length of
the
stem.
operating length of the entire scope, I don't remember exactly. The length of the basket is a little bit more than what the scope length is. What I use is a different scope, so I know the dimensions of that. Irrigate. So what I'm going to do is also apply external pressure.
Yeah. Normally, if the length is good enough,
Yeah.
Dr. Ghan would go beyond the stone and then open the basket. Shirish, am I right?
Yes.
Yeah.
So probably I've gone beyond now. Can you see the highland?
Yes. Yes.
Yeah. So I've gone beyond.
Yeah.
I'll keep the basket in an open position. For the audience, I had shown this schematic video in my presentation. Irrigate. I can now see
Stone
probably
getting.
yeah.
Yeah.
I'm trying to trap it. It's not all that easy as it looks.
Look at the PIP, what he is doing with his fingers, also.
Yeah, that is important. Exactly. See, it slipped, went.
Yeah.
Yeah.
Yeah. See, what is happening is seen in the circle, but what he is doing is seen in the rectangle. And both things are important simultaneously.
It's like in fishing, you have to be patient.
Yes, sir. Where do you get it?
Probably we have another basket which is longer. I might use that.
Yes.
Because this doesn't seem to work.
Yes.
Other basket, please. Datta, check the other basket that they give. So in the meantime, any questions?
We have Dr. Pagare and Dr. Lele coming over here.
Oh, that's an honor. Both of them are esteemed members of our Nasik ENT group.
Yes.
Hi, Shirish.
Hi. You both must have traveled together.
Yeah, absolutely.
No surprises there.
we Department of ENT, SMBT and Maxillofacial Department welcomes Dr. Pushkar Lele sir and Dr. Rajendra Pagari sir. Thank you, sir.
Give me both the baskets, don't worry. Give me the one with the blue handle. While we were talking about the papilla, I remember at least 4 or 5 cases where I spent more than an hour finding the papilla.
Yes, Shirish.
Now another basket, let's see if it goes through this instrument channel.
It is indeed painful sometimes to not being able to pass through the papillae.
Yes.
And I know at least 3 occasions when I had to give up,
Right.
give up surgery right at the beginning. I mean, you just
Yes.
can't insert the scope.
And that is the reason why I said, I mean, the chances we can reduce by knowing more and more variations in the anatomy. Irrigate. Can you see this vasculature now?
Yes, very clearly.
Yeah. When we increase the saline pressure, we can see the capillary blood flow stopping.
We can see what popping?
The capillary blood flow stopping.
Correct,
and
correct.
then again resuming.
Correct, correct, correct.
Here's the stone.
Yes.
Let me see, where is my basket? I'm pushing it in. There it goes.
Yeah.
Okay, but the situation is it doesn't have too much space to open beyond the stone. So, open, close, question. I'm going to ask this is a longer basket, so my assistant is going to open and close. Yeah. Open. Open completely. Okay.
Instead of fishing, you are stoning, is it?
Yeah. Irrigate.
Achha.
And I'm happy that
it's too big, yes.
we are facing this problem. Otherwise, SIALENDOSCOPY, I mean, first attempt you go and remove the stone.
Yes.
It's just this behind this curve with the duct.
Behind this?
This curve, the one that is coming from 9 o'clock to 6 o'clock. The moment I withdraw distal to that, the vision is lost. I don't see the entire, yeah. Okay, now slowly close the basket, slowly. Just a moment, very slow. Okay, close it. No, open. See, unless and until we encircle the stone, we will not be able to trap it.
Correct, correct. Yeah.
I mean, basic physics. Yeah. Now slowly close it. Close it slowly. Slowly. More. 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 Can you see?
Yes, sir. Superb.
So actually all this clapping goes to my assistant Datta because he was. Give me the pottery. Give me the other small section. Datta, you can come from this side. Ask the sister to be there. So she will. Sister, तुम्ही मला तिकडनं instruments लागतील ते द्या. Do you have the microscopic picture in view?
Yes.
Okay. Centralized and focused or no?
Not centralized, focused, yes.
Okay.
Yeah, now it's centralized, yes.
Okay. Cutting किती वर आहे? 15 वर करा.
Sometimes, yes.
So if you can see, this is the basket end.
Yeah,
Okay?
yeah,
And probably here is the stone. Okay, here, the yellow thing.
correct.
Can you see that?
Correct.
Now,
yeah.
one way of doing it is cutting through and through to the papilla.
Huh.
But as I said, the papilla is a sphincter.
Uh-huh.
And we need to maintain it. So rather than cutting through the papilla, I will cut directly over the stone, a little proximal to the papilla,
Uh-huh.
so that we don't cut the muscle of the papilla.
Sphincter, yeah.
Yeah. केलं कमी?
Do you not cut sometimes the basket
Yes,
threads?
it can happen.
That is protection. Sleeve. जरा लंबी है वो.
Can you see the stone?
Yes, sir.
Suction.
It's like caput presentation, is it? Yeah.
When I was doing my MO-ship at Dahanu,
Uh-huh.
I was not at all interested in gynec and obs, but the person there wanted me to continue with that.
Uh-huh.
So once he took me to the labor room, and when it was a like vertex presentation, I said it's a breech. If it was left occipital anterior, I would say it is a right occipital anterior.
All right. Perfect.
Yeah. So, I mean, you cannot say, and I would know all the theory. I would say, sir, here is the spine, here is the vertex I can feel. So sometimes you have to be clever enough to act dumb.
Yes.
Can you see the wire now?
Yes.
Give me the cautery further. Cautery.
How do you prevent wire being cut? I mean,
Yeah, I mean,
you can
just,
still cut
yeah, see, you can start seeing the wire, okay?
through the tissues. Yeah.
Yeah. So just be careful.
Yeah.
That's the only thing. Give me that ball point. Smaller one, yes. So, as I said, this ball point works very well for us. You can see I'm trying to deliver it. Can you now see
Yes.
the stone trapped in the basket?
Yes.
For 6
Centralize, please.
Yeah, I'll centralize. Tongue retraction. Am I centralized?
No, not yet, but it's all right. Yeah, yeah, much better now. Yeah,
Okay. So you can see the basket coming in through the papilla.
yeah,
It is the plane forceps. And it is now trapping the stone which I have delivered through the incision,
yeah,
right?
yeah,
Now I'm going to take this out,
yeah.
and here comes the stone, right?
Wow, superb.
Now, if you can see, I'm going to close the basket.
Can't see, but anyway. Hey, show the endoscope picture, please, for a while.
No,
Microscope.
the endoscope is still
Microscope picture.
Yeah.
Yeah.
Can you see the microscope?
Yes.
Or no?
Yeah. Now we can
Section?
see.
Yeah.
Now we can see it's closed. Yes.
Yeah.
The basket is closed now.
Yeah.
Yeah.
So I'm going to withdraw it. Okay?
Yeah.
It is going to come out.
Yeah. Yeah.
Yeah. Let it come on this side. I'm now going to load a guide wire. Now I'm going to go in through the papilla, through the incision into the proximal ductal system.
All right. Yeah.
Right. Confirm that I am there. मला 18 नंबरचा वेन फ्लो लागेल. दत्तक सक्शन टिप दे malleable. Five zero Mersil, 50 Vicryl. Guide wire in the scope. हं. 18-16चाही आहे का? बरं ठीक आहे. 16चा असेल तर आणून ठेवा. Maybe we might use it. So are you still getting the microscopic picture?
Yes. No, not
Indorwala, sir?
microscope. Yes. Yes, microscope
Right.
picture now.
So
Yeah.
you can see I am going
Through the papilla.
papilla.
Yeah.
I have gone in, I can feel I have gone in.
Yeah.
Okay. Now I can see that. Right. Now give the endoscopic picture to the audience, this camera. So are you getting the endoscopic
Yes,
picture?
we are getting. Yes.
Datta, irrigate. Are you getting the
We can see the
endoscopic
guide
picture?
wire also. Yeah.
Yeah, okay. Clearly we are in the hilum.
Yes. We can see a bifurcation in carina also. Yeah. Yeah.
So the advantage is we can deal with any other pathology. If there is a small fragment staying there, we can do that, which we cannot do if we had no endoscope. So we are
Right.
confirming that there is nothing inside other than what was there.
Yeah.
As you can see, there will, as I withdraw, you will see another septation. You
Yes.
can see
Third
another
one. Yeah.
tributary.
Yeah.
So this is the region of the hilum.
Uh-huh.
I am coming out. You can see another opening, small tributary over here at.
Fourth one. Yeah.
Yeah.
I can see. Yeah. We can see.
And you can now see this side.
What is that? Opening.
So we are going to go in, irrigate. This is,
Surgical opening, is it?
yeah.
Yeah.
So again I have gone in, confirmed, I am in the duct.
Yeah.
I am going to withdraw. When we come to that section, that's the surgical opening.
Yes. Yeah.
And I am going to come out
Yes.
with the guide wire in the duct. So I am now nearly out.
Yeah.
This is, I mean, you can see the guide wire in the papilla now.
Correct.
Right. I want the stent get onto the microscopic picture.
We have the picture now.
Yeah. So external camera, come a little closer.
Yeah, we can see ethylon. What is
No,
it?
that's the guide wire.
Yeah, guide wire. All right.
घातलं होतं तू बरोबर. मी कमी घाल. दे. हे धर. So that's the guide wire which was in C2. I have just removed the scope, keeping the guide wire in place. Can you see this?
Yes.
So this stent has gone over the guide wire now.
Uh-huh.
It will travel nowhere else but where the guide wire is.
Yes.
So I am going to show you where it goes. So for this, we have special stents which we don't have here. But for this, what I am going to do is go through and through the lumen of the stent.
Uh-huh.
See, my incision is here. The stent is quite long.
Yeah.
Right. So I am not worried about the length of the stent.
Mm-hmm.
You can see I am going in through.
Through the stent, yeah.
Yeah.
And through the guide wire also.
It doesn't go. It goes by the side if you see clearly.
Yeah, yeah. No, I'm just.
It cannot go in through the guide wire.
Yeah.
Now, the good thing about the floor of the mouth is to anchor this stent. Close by, we have a raphe of connective tissue. That's the frenulum of the tongue. Can you see the frenulum of the tongue here?
Correct, yes.
So I am going to get my bite of mucosa through it.
All right.
But at the same time, if this is the papilla, there is a papilla somewhere here.
Correct.
If this is the duct, there is a duct somewhere here. So
Yeah.
if I take a deeper bite, I might cause an obstruction on the other side.
Correct.
So land him into another problem or her. So just be careful about this stitch. You can see this is how I will keep the stent in place before I suture the duct.
Yeah.
Scissors. I ask the patient to follow up on day 1 and day 4. So on the 4th day I will remove in this case. But if it was a stricture,
All
I would
right.
like to keep it for around 2 weeks.
All right. Yeah.
Give me the other section.
Now, do you suture this in 2 layers?
No. I mean, you can. I have done that and I have found no difference between the two.
All right.
See, the natural passage of saliva is now patent with a
Yes.
stent in place.
Correct.
And the floor of mouth has excellent healing properties.
Perfect. Yeah. In fact, even if you don't suture, it's all
Yeah,
right.
that is also fine.
Yeah.
I mean, people have left it without stents. Can you see the stent now?
Yes.
Can you
Can you
see?
centralize, please?
Yeah.
Yes. Now again show once more.
Yeah, I'll show it to you.
Yes, sir.
Can you see it
Yes.
going into the duct?
Yes. Focus it just for the sake of
Okay.
excellence of it.
Yeah.
Yeah. Perfect. Yeah.
Can you see now?
Yes. Yes. Yeah.
Convinced?
Convinced.
Right.
I mean, it was
And-
already there. Just wanted.
And, yeah. We have kept this much of distance, so we have preserved the muscle of the papilla. Between the
Yes.
incision and the papilla, there is some tissue remaining.
Yeah, we can't see that, but we understand. Yeah, that's it.
Yeah.
I hope for everybody, you understand that there is a distance between the incision
Sir,
and
can
the
you now
papilla.
see it?
Yes, very clear. Yeah.
Okay. So I'm just going to take a Vicryl 50 Vicryl stitch. One single stitch should be sufficient.
Now, actually, once you have a natural pathway established, the fistulae or openings that you have made will always close.
Heal. Correct.
So you may not necessarily close this, but it's nice to close it.
Yes. I mean, the patient is going to peep inside the mouth and see an open wound there.
Yes.
Yeah. He is going to be terrified of it.
Yeah. Yeah. Yeah.
Give me a wet gauze piece. Give me that big scissor. I'm going to shorten the stent a bit. See now, because the tongue is being retracted, just leave this.
Yeah.
Then that small piece of stent has gone out. Give me a number 3 dilator. Okay. A bigger one. Number 3. I'm just, the stent while getting cut got compressed a bit. So I'm going to just resume it to its normal shape.
Yeah. Yeah. Yeah.
And that is the end of the surgery. One functioning organ preserved.
Yes, sir. We get the message very clear, loud and clear.
Thank you everybody in the OR, the anesthetist team, the nurses, the OT assistants, the audio visuals, and obviously to Dr. Leena Jain and the ENT department and SMBT for arranging such a wonderful facility. And it was a pleasure doing this case over here.
And thank you, audiovisual, for showing us the faces of everybody. It's indeed nice. It's indeed nice. Thank you so much.
Right.
Very thoughtful of audiovisual people. And let me tell you, Shirish, one thing.
Right.
I don't find anything great when you do this surgery.
Right.
Because I also do it.
Right.
But,
Exactly.
but, no, now the real thing comes in.
Yeah, I know it was going to come.
The art with which you do it is unbeatable. It's absolutely mesmerizing. Thank you so much for that.
Sir,
I cannot match that art of yours.
sir, this compliment coming from you, I know it's a genuine compliment, and it is something which I will hold with me until I go to my grave. Thank you, sir.
Yes, sir. Thank you.
Sir, Ghan sir, thank you so much for such a wonderful demonstration.
Thank you. Where's the stores guy?
Ah,
Take the scope into your hand. Working condition, I have given it back to you. Okay?